Ascites. Ascites refers to the excessive accumulation of free fluid in the peritoneal cavity. Management of ascites. First, we have to take the history about onset and progression of the symptoms, past history of jaundice, hematemesis, tuberculosis, rheumatoid heart disease, etc. should be taken. Personal history like alcoholism and family history such as cirrhosis, Wilson's disease, hemochromatosis is checked. History of heart disease and renal disease is assessed. Then clinical examination is done. In general examination, we see if hepatic facies, then high cerebral functions such as confusion, disorientation, and disturbed sleep pattern, etc. We can find puffiness of the face with periorbital edema in case of nephrotic syndrome. Lymphadenopathy is seen in tuberculosis, malignancy, and collagen vascular disease. Raised jugular vein pressure and cyanosis is found in heart failure. Clubbing of the fingers and then stigmata of chronic liver disease is found. These stigmata are spider nevi, gynecomastia, testicular atrophy, loss of axillary and pubic hair, etc. Then palmar erythema, pedal edema, and signs of nutritional deficiency such as angular stomatitis, cheolosis, anemia, atrophy of tongue, muscle wasting, pigmentation of tongue and mucous membrane may be present. By examining the abdomen, abdominal distension with fullness in the flank may be found. There may be dilated superficial abdominal veins, eversion of umbilicus, then abdominal stria may be found. Shifting dullness may be found on percussion. When ascites is marked, a fluid thrill is present. The associated features of ascites are distortion or eversion of the umbilicus, then hernia, abdominal stria, divarication of recti and scrotal edema. Pleural effusion are found in 10% of the patient. Splenomegaly and hepatomegaly may be found. The investigations are, we have to analyze the ascitic fluid and its appearance, then ascitic albumin level is checked, plus serum albumin level is also checked. Then white cell count is seen, which can be 250 into 10 to the power 6 per liter, which strongly suggests infection, which may be spontaneous bacterial peritonitis. Cytology of ascitic fluid is done for malignant cell, microscopy and culture, and ascitic amylase is checked. Ascitic amylase is increased in ascites due to pancreatitis. Then serum albumin and total protein level is checked. Ultrasonography of the whole abdomen is done. Liver function tests are done if chronic liver disease is suspected. Complete blood count with ESR is done for detecting infection. Chest X-ray is done for TB, cardiomegaly, chronic congestive pericarditis. CT scan or MRI is done for detection of any growth or mass. Treatment option of ascites are: first we have to control the ascites by sodium and water restriction. The daily sodium intake should be less than 100 millimole. No added salt should be taken, and restriction of water intake uh, is done to 1 to 1.5 liter per day. Sodium retaining drugs such as NSAIDs, corticosteroids should be avoided. Diuretic drugs such as spironolactones 100 to 400 milligram per day is the drug of choice for long-term therapy because it is powerful aldosterone antagonist, but it can cause painful gynecomastia and hyperkalemia. Some patients will also require powerful loop diuretics such as furosemide. Paracentesis is done 3 to 5 liters daily is safe provided the circulation is supported by giving intravenous colloids such as human albumin 6 to 8 gram per liter of ascites removed or another plasma expander. Then peritoneovenous or leave and shunt is done. The peritoneovenous shunt is a long tube with a non-return valve running subcutaneously from the peritoneum to the internal jugular vein in the neck, which allows ascitic fluid to pass directly into the systemic circulation. Transjugular intrahepatic portosystemic stent shunt or TIPSS is also done. Then specific treatment is done according to the diagnosis.